Onc Live Insights is a video editorial program produced by Onc Live.
We typically change treatment, like in most cancers, when patients either progress or develop intolerance of the drug, despite dose changes or dose reductions. In some cases, such as with chemotherapy, we won't actually treat until disease progression, but rather until maximal response, although different doctors have different strategies with respect to that. With respect to somatostatin analogs, specifically octreotide or lanreotide, when they're used for their anti-proliferative effect, in other words, to inhibit tumor growth, it's unclear whether continuation beyond first disease progression is of any benefit. And some patients who are progressing very slowly on somatostatin analogs will sometimes continue those even while initiating another treatment, such as everolimus or sunitinib, whereas in patients who are progressing quickly, we'll discontinue the drugs. For patients with tumors that are growing relatively quickly, I tend to turn to chemotherapy, and the regimen I use most frequently is capecitabine temozolomide. For patients with slower growing tumors, I often choose between everolimus and sunitinib. The question of sequencing is a very hot topic in pancreatic neuroendocrine tumors because we have a variety of clinical trials, but none comparing one choice to another. And so it's a bit of a guesswork trying to figure out which is the right drug for the right patient. We also don't have any good predictive or prognostic factors really for any of these approaches. And so it really becomes a question of what the oncologist is most comfortable with. But the good thing is that there's multiple treatment choices for patients, and we can often go through 4 or 5 lines of therapy and probably extend patient survival significantly as a result of that. In the first line setting, I tip with a patient with a well-differentiated tumor that's somatostatin receptor positive on octreoscan. I'll typically start with a somatostatin analog, either octreotide or lanreotide. If the patient is progressing relatively quickly, I typically choose capecitabine temozolomide as a second-line therapy. In many cases, we'll see an objective radiographic response and treat until maximal response, at which point we'll take a break from treatment. If the patient progresses long after they complete their first-line chemotherapy, say a year or 2 later, we'll often repeat the chemotherapy to see if they can have a second response. Otherwise, we'll move typically to a targeted agent, either everolimus or sunitinib, often depending on patient comorbidities and preference. Other approaches that we often integrate into treatment include liver-directed therapy, hepatic artery embolization. At our institution, we typically perform bland liver embolizations, although other institutions do chemoembolizations and radioembolizations, and are advocates of each particular technique. I think peptide receptor radiotherapy with radiolabeled somatostatin analogs represents a very promising novel approach that may be widely available in the United States in the near future.
In terms of which patients who should receive which type of treatment, I usually think of the disease in 2 dimensions. One is really the amount of tumor that is there, so the tumor burden. The other is the aggressiveness of the tumor, whether it's the rate of progression or high Ki-67 or high tumor markers showing a high risk of progression. So just the aggressiveness. In patients who I would say have low tumor burden and more stable disease and less aggressive disease, I typically start with a somatostatin analog. In patient on the other extreme end, very high tumor burden, very symptomatic and progressing rapidly, cytotoxic chemotherapy is the one I would start first. And everywhere in between, is where I would do targeted therapy with either everolimus or sunitinib. In terms of the use of more regional therapy approaches like hepatic artery embolization or chemoembolization or radioembolization, I usually do that in patients who has slowly progressive disease but accumulated a large burden of tumor over a long period of time. So in those people who have a lot of disease but it's very slow moving over a long period of time. Debulking, whether it's with embolization or radioembolization, can lead to lasting benefit in those patients.
There are a number of treatments that can be used for patients with advanced pancreatic neuroendocrine tumors. And one of the questions that has come up, given that we now have several choices, is which one do you use first, which one do you use second, which one do you use third? And there really have been no studies that have established a standard sequence. What many of us do first is start with the somatostatin analog. And the reason we do that is, number one, that we now have the results of the Clarinet study, which showed that in patients who have pancreatic neuroendocrine tumors, somatostatin analogs, in that case lanreotide, can significantly improve progression-free survival. Lanreotide is well tolerated, has very few side effects, so that's a logical first choice to treat patients. In patients who progress on a somatostatin analog, the choice becomes a little bit more complicated, because then we have to choose between a targeted agent like everolimus or sunitinib, or a chemotherapy, which can also be effective. Often we think about temozolomide in that setting. There you really have to think about what your goal of treatment is. If the goal is to just improve progression-free survival and stop the tumors from growing, we'll usually go to one of the targeted agents, everolimus or sunitinib. If the goal is to try to shrink the tumor down, if the patient is having symptoms of tumor bulk, we might in that scenario select a chemotherapy to give us a better chance of shrinking the tumor. The choice of therapy really depends on the patient and what the goals of treatment are and whether that patient has symptoms. And based on what's going on with the patient, we have a variety of different options now to treat them and to try to help them.